and what lies ahead as far as genetic therapy for inherited disorders of the eye, specifically inherited disorders of the anterior segment. So I have no disclosures related to the subject of this presentation. So the first half of this talk, and Jerry, I have 15 minutes, is that right?
Yes, sir, even more if you need.
Even more if I need. Okay, good. That's dangerous because I can go for a while, but I won't. We'll talk first about clinical utility of molecular genetic testing, and then second, genetic therapy for inherited corneal disorders. This is going to be interactive. All right, so I want everybody to be watching these slides, and I want you not to look at your handout when I'm going over these cases. So I ask you to please close your handouts so you can experience these cases as I did with these people presenting these various problems. We'll work through them together. So the first question is genetic testing even necessary? Many of you in the audience say, well, I see a patient, let's say, how many people here are corneal specialists? One. Okay, how many people here are retina specialists? Couple. Okay, and the rest are comprehensive ophthalmologists, or we have any glaucoma people here, or peds people? Any pediatric ophthalmologists? Okay. So you may say, okay, I'm a comprehensive ophthalmologist, I'm a retina specialist, I'm a corneal specialist. I don't really see a need for genetic testing in my practice. Well, I would say that if you rely on family history, if you rely on recognizing characteristic clinical features at the slit lamp to differentiate between what may be a dystrophic condition and something that's not dystrophic, that you're going to miss some things. Because inherited disorders often do not have a positive family history, even in dominantly inherited disorders. And they often have an unusual phenotype, clinical appearance, that may fool you. So you may be seeing these inherited conditions, but you're not recognizing them. And the only way really to definitively differentiate between an inherited and non-inherited disorder is through molecular genetic testing. So we're going to do a case here. This is a patient who presented to me. She's a physician, 39 years old. She's a intensivist, interested in LASIK surgery. She presented not to me, to local refractive surgeon. She came to see me later for evaluation. Has a family history of granular corneal dystrophy. Glasses and contact lenses worn in the past for correction of moderate myopia and astigmatism. Family history significant for mother and two sisters with granular. So here's the right eye. You see a few deposits. These are in the anterior stroma, fairly small. And you can see why she still sees 6/6, because these don't affect her vision. Here we are, higher magnification. And here we are in the left eye, only a single dystrophic deposit. So if this patient comes to you and wants to have LASIK surgery, otherwise is a good candidate, would anybody in the room not perform LASIK surgery for this woman? Okay, how many people here would perform LASIK surgery given that she's otherwise a good candidate? Okay, you guys have to raise one arm. We're going to do this again. This patient comes to you, wants to have LASIK surgery. She's a -4 sphere myope. No dry eyes, normal central pachymetry, all the parameters that you need to look at to determine whether a LASIK candidate are fine. She has these little tiny deposits in her corneas that don't affect her vision. How many people would go ahead and proceed with LASIK surgery for her? How many people would not perform LASIK surgery for her? Okay, so for this half where nobody voted, are you guys listening to me? Okay, you're not going to get anything out of this talk unless you're not listening and interacting. How many people would perform, just vote, you're not going to be held liable. There's no malpractice lawyer listening to this conversation. How many people would do LASIK for her? How many people would not perform LASIK surgery? Okay, why are you guys not performing LASIK surgery for her? She has cash. She has crisp 1,000 rupee notes. And lots of friends who are waiting to see if she does well, she's going to send all of her friends. And you're tired of doing retina. You think, I can't make a living doing membrane peels. I need to start doing ketorefractive surgery. So you end up deciding to do the surgery. And you know what? You're glad you did it. You did LASIK, and a year later, you did an enhancement for her. She's 6'6". Then she goes on her merry way. You don't see her again until she comes back 4 years later, and she says, my vision is a little bit declining. So for those of you who have trouble seeing the deposits here, I'll outline them. See the little white things in the cornea? That's usually not a good outcome after LASIK surgery. Here we are, nice shot in retroillumination. Okay, an OCT in this patient. We see this hyperechoic line here. What is this? What does that represent? Increased density. That's the flap, exactly. That's the LASIK flap interface. So we have an acceleration of deposits, of these dystrophic deposits occurring at the interface. A different patient, This gentleman had no family history of any corneal dystrophy. He had nothing on examination. This is a patient from San Francisco, as asked to see. And then this is the eye 2 years later with all these dystrophic deposits, what are presumed to be dystrophic. And again, on the thin slit beam, you can see right there that these are all at the LASIK interface. Another patient. So I've seen this 3 times now. This patient went on to bilateral penetrating keratoplasties. Not usually the thing you want to do after you do LASIK, doing bilateral penetrating keratoplasties. In all these patients, and at least that one had PKs, we see that here's the LASIK flap interface, staining red with this Masson trichrome stain. Here's a dystrophic deposit in the anterior stroma. Classic finding here in a patient with granular corneal dystrophy. But it wasn't actually granular. Genetic testing showed a mutation. Here we're on exon 4 of the TGF-beta-I gene. You don't have to know all this, but Dr. Schultz already talked about the bases. We know that 3 nucleotides encode for a codon. In this case, these 3 encode for arginine. In this patient, she had a nucleotide substitution that had caused an amino acid change, and this is the classic mutation associated with Avellino corneal dystrophy, or combined granulomatous corneal dystrophy. All the cases in the literature of acceleration of these deposits occurring after LASIK surgery are in patients who have combined granulomatous corneal dystrophy. Could this happen with somebody with lattice dystrophy? Yes. Or granular. Any dystrophy associated with mutation in this gene can have this phenomenon occur. It's been reported in patients with combined granulomatous because these folks have a later onset of these deposits in the cornea. So that when they're 24, 25, 28 years old even, coming in for a LASIK evaluation, there may not be anything to see. Whereas somebody with lattice or granular dystrophies would have obvious disease and would scare away most refractive surgeons, other than those in Los Angeles who would still probably go ahead with surgery. So in this case, anybody who does refractive surgery in this room should have a question on their questionnaire about any family history of need for corneal transplant, any inherited disease of the cornea. If that's checked yes, you then have to ask the patient what disease they have. They may say keratoconus. Okay, well then you also need to, of course, be very careful about doing refractive surgery. But if it's a dystrophy, if they're a younger patient, like if they're, let's say, 25 years old, you have to do genetic testing to exclude this condition because they may not show any deposits in the cornea at all, or if a very subtle deposit may miss. And if you do LASIK surgery, that's going to happen. And because it's been reported in the literature a number of times, it's out there, so you're responsible for knowing it, so that's malpractice, and you will be sued. Definitely refractive surgery patients have a lower threshold for suing, so you have to know it to give good care and to protect yourself medico-legally. Okay, another patient, this one 65-year-old gentleman, presented to me with slowly progressive decrease in vision over previous several years. Is referred by his ophthalmologist in Phoenix, Arizona. No history of trauma, no history of recurrent corneal erosions, no family history whatsoever. Again, several years history of declining vision. On examination, we see these branching thin lines in the cornea diffusely distributed in both corneas. That's the right eye, and here's the left eye. You can see this very long line. You can see a nice branching pattern here with some punctate opacities between the branching opacities. What is this condition? Lattice dystrophy. It certainly looks like lattice dystrophy, but is lattice dystrophy inherited in a dominant or recessive fashion? Dominant, right. You need to know some of these basics, and that's why you're here today, reinforcing these. So if this is a dominant disease, a family member, i.e. a parent, should be affected. He said there's no family history. The rest of his family is not accessible for testing. So what do I do with this guy? He came all the way from Phoenix on a bus. He said, I want to see the man who knows everything. He sees me, he's like, you look too young to know anything. I said, God bless you. Your vision is obviously not good. So what do we do with this guy? What do we do for the last patient? Genetic testing. Okay, so that's what we did. So, interestingly, same gene, same exon, same codon, codon 124. Mutations at this codon cause Bowman's layer dystrophies, combined granulomatous or Avellino dystrophy, as well as lattice dystrophy. So this gene is very amenable to screening your patients because we have these hot spots where the lab only needs to look in 1 or 2 locations to be able to include or exclude a diagnosis in about 95% of patients. So here are the 3 nucleotides that make up arginine, and his sequence looks the same as the wild type or normal sequence. So he does not have lattice dystrophy. Now what do we do with him? What would he do if he's your patient you see and you get back home after the meeting today? Say next week you see this guy, you say, okay, I remember what Aldave said. I did the genetic testing. I sent these samples off, and we'll go over that in a moment. Now what do you do? Anybody can chime in here. Do you just tell them we don't know what this is? Whose cornea again? Now there's no hands. Okay, your cornea, he's going to be coming to you. What do? You emailed me and I don't respond. So I'm somewhere, God knows where I am. Some corner of the earth where there's no email. Antarctica. What is this material that we think is in the cornea? Does anybody know that? Amyloid. Okay. There are different types of amyloid. There's primary and there's secondary, right? And there's localized and diffuse. It could be systemic. Could this be systemic amyloid deposition? How do we look for that? What's that?
Rectal biopsy.
Rectal biopsy? You would not do well in Los Angeles. If you start recommending rectal biopsies, other than maybe a state penitentiary, they'd like that. That's not going to go over big. But your idea is spot on. This gentleman has monoclonal gammopathy. He has a myelodysplasia. Anytime you have what looks like lattice in the cornea, without a family history, especially remember this guy had late onset. He's 65. He says vision was fine until a couple years ago. That's not characteristic of lattice. That's usually early on, as you know, visual difficulties, current erosions when they're in their teens. So if somebody has onset of deposits by history in their 60s without family history, you have to do genetic testing. There are forms of lattice dystrophy that have late onset. So doing genetic testing is simple, it's easy, and many times we give the diagnosis. When it is negative, then the next step is what we did here. Look for systemic amyloid deposition. And I have found this half a dozen times. If you miss cancer in a patient, that is the best way to get sued. Better even than doing LASIK on somebody with granular dystrophy. If you really want to get sued quickly, at least in the United States, miss somebody's cancer for a while. And here the ophthalmologist has the chance and the obligation to recognize this condition, do the appropriate workup, and send the patient to the oncologist as I did here. Here's another patient who came to see me. She was diagnosed by 3 other corneal specialists with enlarged corneal nerves, interstitial keratitis, and I don't even know what the other diagnosis was. It was some crazy thing. So in this case, she had deep crisscrossing lines in the cornea. Didn't look classic for lattice. They looked more like large corneal nerves, as you see here, but looked funny to me. Again, we did a workup, a UPEP and an SPEP, serum protein electrophoresis, also has monoclonal gammopathy, presenting as ophthalmic findings. This patient was followed by one of my fellows, not the one who's in the back of the room, fortunately, but one of my prior fellows, followed with Schneider corneal dystrophy. We know the gene for Schneider dystrophy. And because this patient had no family history, they had crystals in the cornea, but no family history, instead of making that presumed diagnosis, he should have tested the gene, which I did, and showed no mutation in the gene. Because anytime you have a 65-year-old patient with crystals in the cornea, no family history of crystalline dystrophies, you got to think about myelodysplasia. This person had multiple myeloma that was watched at our institute for 2 years before treatment was given. That is malpractice, and you will not commit that malpractice because you will recognize this and say that person needs genetic testing. And yet another case of the same thing. So if you rely on the clinical findings to diagnose corneal dystrophies, you're often going to be wrong, because those that appear dystrophic may actually be degenerative. These 2 patients have what look like lattice dystrophy with these lines in the cornea. Both of these have localized secondary amyloidosis. One secondary to recurrent corneal erosions, the other patient secondary to trichiasis, and I've published both these cases. On the flip side also, it's true, clinical features that appear degenerative may actually be dystrophic. There's a condition that cornea people know about called polymorphic amyloid degeneration. It looks like lattice, but instead of lines, it looks like you chopped up the lines and put them in a blender and put them back in the cornea. Very short pieces of what looks like amyloid in the cornea, classic for polymorphic amyloid degeneration. But here's a patient who's a member of a large family with a variant of lattice corneal dystrophy, which looks the same. Significance? This will never need surgery, never impairs the patient's vision. This person, everybody in their family has required corneal transplantation. So you cannot tell dystrophy from a degeneration by looking at it. Sometimes you must have genetic therapy. Even in a same family, where the different individuals carry the same mutation, they've had same environmental exposure, you can still have a very different phenotype. So this person and this person are siblings. This patient has lattice lines in the corneal stroma. Bowman's layer is clear. This individual has Bowman's layer deposits. You can see them here quite elevated with a totally clear stroma. They carry the same mutation. So you can't rely on what things look like to try to categorize them and think about what's causing it, because you can have significant, even intrafamilial variability. And also, if you rely on what you're taught as a resident, that dystrophies are typically bilateral and symmetric, you're going to be wrong sometimes. This is one of several patients I've seen that we've published who have totally unilateral involvement. Lattice lines, thin ones here in the right eye, nothing in the left eye. This person's in their 70s. So it's not like this is early onset of this. This has been in this way for 6 decades. So dystrophies may be bilateral and may fool you. And also, because the dystrophies take on a different appearance at the different ages of the individual who's affected, the phenotype is very much age dependent. These two individuals just had fairly subtle grayish epithelial opacities, as you see here. You know, if you use applanation tonometry, you touch the patient's cornea to check the pressure, then you remove the applanation tip, then you look again at the cornea, you can often see what looks sort of like the imprint from the tonometer tip. That's what this looked like. But if you look at their mothers, this one had this placoid opacity associated with lattice lines. This is a variant of lattice dystrophy. And this mom had classic corneal crystals associated with crystalline corneal dystrophy of Schneider corneal dystrophy. So very different dystrophies look the same when individuals are young. So if somebody brings, some of your pediatric ophthalmologists or general ophthalmologists, your child is brought to you to diagnose them, you can't make the diagnosis correctly based often on what you just see at the slit lamp for the individual. And also, don't always rely on a positive family history, even for a dominantly inherited disorder. This child history of recurrent corneal erosions, neither parent affected, classic Bowman layer dystrophy, which I proved it to be, and proved it to be a spontaneous mutation. And this has been published several times before in the literature. This patient came to me for LASIK surgery, what looked like Meesman's corneal dystrophy. He had 12 siblings, not a single one affected, yet he still has Meesman's dystrophy as proven by screening of the genes that cause Meesman's. So in that case, the large family, still nobody affected. So you say, okay, well, maybe there's certain cases in my practice where I would like to have genetic testing performed. How do I go about doing this? I'm in Cochin here, I'm in Mumbai, I'm in Delhi, I don't know who's doing this in my location. Do I have to get consent from the patient? What's involved as far as what sort of DNA do I have to get from the patient? Do I have to do the rectal biopsy that was suggested earlier? Or can I do something that's maybe less benign and less smelly? And most importantly, who's paying for this? I mean, this is all interesting stuff, but bottom line, at the end of the day, someone's got to pay for this. There's 2 different types of labs to which you can send DNA samples. First is a research lab like what I have at Jules Steiner Institute. The advantage of usually a research lab is university-based. So if you're in Delhi, it might be at Ames. If you're in Chennai, it might be at Shankaranathraya or somewhere else like that. Genetic analysis is performed under IRB approval. So patient consent is required. The costs associated with specimen collection, transportation, analysis are typically covered by research funding. So that's what's nice. So if you know somebody in your area to whom the patient can go, that person's research lab typically takes care of all the expenses, and that frees you up. The genetic testing is also able to not just identify previously reported mutations, but also to look in other genes that lab may have identified as being caused or associated with this condition. However, these research labs often, since they're not certified by the government or some accreditation agency, may not be able to give you validation of the results. So they always said this is for research purpose only. So that really, for you to be able to act as a clinician on the results, these results may need to be repeated by a certified laboratory. And those certified laboratories are often called diagnostic laboratories. In the United States, and I think also here in India, you can send samples to the Carver Laboratory, C-A-R-V-E-R. So it's carverlab.org is their website, if I'm not mistaken. And this is a lab that is well funded. They do testing at cost. Takes about 12 weeks for a turnaround. U.S., it's about $160 now for them to do genetic testing. There's also a lab that's in Estonia, so that's closer to you here in India. So this is in Europe. This is Asper Biomedicals. And they have a chip in which they will test for 333 mutations in 13 different genes associated with corneal dystrophies. So it's sort of a buckshot approach to finding the mutation. These are university-based or private, that being diagnostic laboratories. They're accredited in the United States. And you don't need research study approval. In this case, you're ordering a test like a complete blood count or a chest x-ray. You don't have to get patient consent, of course, for those. The costs associated, however, with the specimen collection, transportation, etc., are paid for by the patient, the requesting physician, or a third party. And they can screen for known mutations, but often, like I said, if you have a chip with 333 mutations on it, if your patient happens to have a mutation not on that chip, it will not be identified. So they can't do all the hunting and sleuthing that a research lab can do. So I tell people it's probably best first to send it to a research lab so they can find what the mutation is, and then send it to a diagnostic lab that's able to confirm that result. What do you send? Saliva. You don't have to worry about rectal biopsies. You don't have to worry about blood. I'm just fixated on this. I'm sorry. The easiest way to do this is send a buccal swab or a saliva sample. This is the newest generation of Origene. This is their website. I have no financial interest, unfortunately, because I think they're a good company making money. But the patient just spits in this, and the saliva, once it's above this line, is all you need. That provides plenty of DNA. The cap is then flipped down, and this, once this blue cap is put on, this could be mailed by regular mail. DNA is very stable. So you can just mail this regular parcel. I usually put it in a padded envelope inside of a Ziploc bag in case it leaks. There are certain regulations regarding shipping, but not nearly as onerous to collect the sample or send it as blood. So you don't need blood necessarily. All right, Don, do I have time for the second part of the talk, or should I stop here and maybe if we have time at the end, continue? Keep going? Okay, so I'm going to stop here, and if time allows, I'm going to talk to you guys about genetic therapy, what's going on right now for inherited disorders. Most of it is in the posterior segment. It'll be interesting to you. I'm also going to talk about some genetic therapy that's currently ongoing for anterior segment disorders, again, if time allows. Thank you very much for your attention.